when we were talking about the imaging modalities, we did it either to explain the role of imaging, or we did it as part of the clinical scenarios. However, today we are going to do it the other way around. We are going to start with the um, malignancy, and then we're going to talk about the role of imaging. We will talk about screening, role of imaging in diagnosis, and in staging, but also beyond diagnosis in a few applications. Now, screening in the medical field implies identifying a disease at an early stage, um, and this is usually a way to sort of secondary prevent the disease. Because if you might remember from your epidemiology knowledge, um, there is a form of a prevention that eliminates underlying risk factors and therefore reduces the overall risk of having a disease. Let's say, for example, cessation of smoking, etc. Um, but we also could limit the disease impact on our health by identifying it at an early stage. And this is in particular important for cancers. But remember that we cannot screen for everything, right? Because we have limited resources. There are also cancers or malignancies that we do very well with them, even if they are malignant. So when we screen for cancer, there are a few things that usually we look for. Number one, the disease has to be prevalent. So the prevalence or the incidence in terms of new cases have to be relatively large. For example, a cancer like melanoma is not common in the kingdom, and therefore it doesn't make sense to screen for it if there were to be a screening test. The second thing, there have to be some kind of known risk factors. For example, in lymphoma, a malignancy that is relatively common in Saudi, but there are no really specific risk factors apart from very few related to rare diseases. Lymphoma, for example, does not have a very specific age preference. We see it in younger, but we also see it in older patients. It also does not have a gender preference. It's common in both males and females, etc. And there is no sort of adjustable risk factor, like, for example, smoking, that we can look for or even adjust. It has to be curable. Obviously, if I'm going to screen for a test but I don't have a treatment for it, then it doesn't make sense to screen for it. And I'm here talking about malignancies. And I'm not talking about infections or whatever, because in infections, for example, like nowadays everybody is overwhelmed with COVID 19, we don't have a treatment, but we still look for it. We still isolate the carriers or the suspected carriers because it's a pandemic. So that's a different story. But when it comes to malignancy, it doesn't make sense that if I don't have a treatment for the disease to screen for it, even though nowadays, it's hard to find a tumor or a malignancy in which no treatment exists whatsoever. There has to be sort of a modification of the disease when diagnosed early. For example, the disease will need to have a relatively good prognosis early on, i.e., the patient expected survival is, let's say, 5 or 10 years. But for example, after screening, after an advanced stage of the disease, the patient prognosis really becomes very low. Now, why is this important? Because if I'm going to detect the patient early when having the cancer, but the prognosis is not going to differ whether I diagnose the patient early or later, then why should I add this additional step of screening? Let me just wait until the patient shows up with symptoms, etc., since the prognosis or the outcome of the patient is going to be poor anyway, or the same anyway. A good example is thyroid cancer. Thyroid cancer is relatively common in Saudi, and yet we don't screen for it, at least not until now. And one of the arguments is that despite its relative prevalence in Saudi, um, the prognosis is actually very good, and it takes a very long time for the disease to move from one stage to the other. And because the thyroid is in the neck and can be easily palpated or felt by the patient himself at a relatively early stage, screening has not been advocated for neither internationally nor in the kingdom. Now, so this is regarding the diseases in which screening would be chosen. But what about the screening test? And I'm here talking about screening tests in general. I'm sure you already know that for a screening test to be acceptable, it needs to have a relatively high sensitivity. We don't need it to have a very high specificity because that can be addressed and filtered as you work up those patients. But definitely you need the test to be quite sensitive, i.e., it allows you to identify the largest possible number of patients. So now we have talked a little bit about screening, and this was just an introduction to give you a sort of a perspective about the role of screening in malignancies. We will come across a number of cancers and malignancies today that screening is appropriate. But I also want you to remember that we should not be screening for everything. As a matter of fact, out of the listed cancers here, there are 3 cancers in which screening has been advised for and has been found to be appropriate worldwide, while one of them has not been yet found to be appropriate to screen for. So let's go through them. Breast cancer, well, it is a leading cancer in the kingdom. There is actually a known risk factor, which is the age. Females who are 40 years and above have a higher risk than younger patients. It doesn't mean that younger patients can't have it, but there is a sort of a increase in the number of cases as patients become older. And treatment in an early stage allows patients to have a better survival, etc. So in breast cancer, obviously, it is appropriate. What about lung cancer? Lung cancer is considered also a leading cause of cancer and cancer-related mortality, not in the kingdom though, but worldwide. In the kingdom, it is ranked lower than others, but worldwide, lung cancer is a leading cause of mortality and cancer related mortality. The disease is linked also to risk factors, in this case, history of smoking. And at the same time, it is seen at older age groups and following a number of years. So there is a sort of a group of individuals that you can apply the screening test on. Colon cancer is also another common malignancy worldwide. It's also common in the kingdom. And again, there are risk factors, at least age. And just like the others, breast and lung cancer, when you screen for those diseases at an early stage, the prognosis and the survival is much better. So I guess now you know what the malignancy in which the screening test is not appropriate for, which is obviously osteosarcoma. Now, osteosarcoma, first of all, it's not a very common malignancy worldwide. We do see it, but it's, for example, ranked usually 10th or below. So there are many other malignancies that are ranked above it. Second, yes, there might be a predilection for younger patients, but we also see the disease in older patients, and unfortunately, the disease does not have other risk factors. So it's almost impossible to screen all the young patients for it because we don't know exactly when does that risk starts. And invariably, in patients with sarcoma, they do present when the disease has become symptomatic, but we don't know whether if we were able to diagnose the disease at an earlier stage, that we would be able to modify it. And we also don't know what would be an appropriate test to screen for it. Let's start with breast cancer and the role of imaging. Now, breast cancer is one of the malignancies in which screening for is appropriate. This is true internationally as well as in the kingdom. Screening usually starts at the age of 40, and it's obviously done for women. Not that men do not get breast cancer ever. There are very low, actually extremely low, incidences of breast cancer in males, but they are obviously far from comparison to women. Now, for breast cancer, we use mammography or a mammogram to screen for. We have already mentioned in previous lectures that the target material is molybdenum with a KH of 20 kV. In order to maximize the photoelectric effect and characteristic radiation, we use lower KVs at an average of 25, and the range is around 35 up to 40. So anywhere between 25, 20 up to 35, 40. The focal spot is also small, and this increases or maximizes the spatial resolution. Both of these features, the photoelectric effect and characteristic radiation, because of its impact on the contrast resolution, and the focal spot as one of the factors influencing spatial resolution, maximizes image quality in mammography and allow it to be a good screening modality for breast cancer. So let's take a look now at this mammogram. Now, mammogram can be done, as we mentioned, both for screening when the patients are asymptomatic, but it can also be used for screening. And irrespective whether it's used for screening or for diagnostic purposes, usually the basic technique is the same. We would get different views of each breast separately simply because the orientation of the breast does not allow them to be imaged at the same time using the current available technology. On the left-hand side, you can see that both breasts are being imaged in the craniocaudal projection, um, and the two images are combined together, usually on the viewer, to allow comparison. The right-hand side two images are for the right and left breasts also, but taken in the mediolateral oblique, abbreviated as MLO. This is a view that is tilted slightly from the more sagittal view, in such a way that the axillary fold is being included. And to ensure that from an imaging quality point of view, we always have to make sure that the axillary fold, the skin itself, which is marked here by the green arrow, is visible on the image. So this indicates that the axillary fold is included. When looking at these images, whether on the right or whether on the CC or the MLO views, and there are obviously other views like the true lateral view, but these are the basic ones. You always want to compare both breasts together. Now, in general, women could vary in the appearance of the breast amongst each other, but for the same woman, usually both breasts appear relatively symmetric because they are influenced by the same factors in terms of age, hormonal effect, history of breastfeeding, etc. The breast contains fibroglandular tissue that over time undergoes transformation into fat, and that's why like in this patient here, the majority of the breast tissue appears to be fat. However, the amount of fat is variable depending on the age and other factors like hormonal factors and some medications. Now, when we look at both breasts, we want to compare side by side. But we also want to look in particular at the glandular areas, like the one here marked by the green circle, and make sure that it's more or less symmetric with the other side. So all of these features help us to interpret a normal mammogram, like in this case, the symmetry of both breasts in terms of fibroglandular tissue and any other changes. Once we have learned roughly how does a normal breast look like, let's take a look at some abnormalities. One of the abnormalities that could be picked up is a spiculated mass. Spiculated is a description of a mass that has very ugly, ill-defined borders that are spreading out of it like spicules. And usually it's a sign of malignancy or cancer. Now, even though I am telling you that on this patient there is a spiculated mass, I'm not sure whether you can see the abnormality. But let's remember that one of the values of having the two breasts on each view against each other is to allow comparison. And I'm sure now, if you start looking on one breast and compare it with the other breast, you will identify one obvious abnormality. which is this speculated mass here. It looks hyperdense, it's ill-defined, it has like lines radiating out of it. This is a very typical appearance of breast cancer. Sometimes the regular or the standard views, which are the CC, the craniocaudal view, or the MLO, mediolateral oblique, or even for some practices they use the lateral view. The ability to detect very tiny abnormalities might not be possible. And that's why one of the way to investigate or work up breast cancer is to use magnified views when you suspect an abnormality in an area that is not very well clear or seen on the standard views. The image on the left-hand side is an example of a magnified view of an abnormality that was suspected on the standard view. In this case, this is the abnormality. So you can see very tiny, speckled-like hyperdensities, which actually represent microcalcifications. Microcalcifications are one of the manifestations of breast cancer. Sometimes they are seen as the only finding, especially in early cancers, but they can also be seen in association with a more advanced mass. Whether for screening in certain situations or for diagnosis in a patient suspected to have cancer, ultrasound have been used as a good imaging modality for breast cancer. Ultrasound is especially helpful in situations where the breasts are dense. So, for example, younger women or women that are not necessarily very young, but for some reasons their breasts are dense, the identification of abnormalities might not be easy, and therefore complementary screening with ultrasound in those patients becomes helpful. Obviously, if there is a suspicion for a mass, either the patient has complained of it or the physician has felt it when examining the patient. And then sometimes on a mammography, we might see microcalcifications, but we don't see an underlying mass. But since this is important for the management of the patient, we do ultrasound to detect or identify underlying masses. These are three different lesions in three different patients. And the ultrasound is demonstrating these lesions in a very good way. Let's start from the upper left-hand side image, where we can see that there is a round anechoic structure and there is a posterior acoustic enhancement. I'm sure you have heard that term before in the lecture on ultrasound. So there is a posterior acoustic enhancement. So the diagnosis is obviously a cyst. This is a very benign finding. It's very commonly found in women of different age groups, and there is nothing to worry about it. The middle image is for a rather hypoechoic lesion, and it is oval in shape. Note that the orientation of the lesion is parallel to the chest wall, which is identified by those more hyperechoic lines. So these are the pre-pectoral chest wall fat, and they actually are a good way to assess the orientation of different lesions. For example, as in this lesion, you can see the orientation is parallel to the underlying tissue. And this is one of the features that suggests benignity. This lesion is a solid lesion, and it was proven to be a fibroadenoma, which is a benign entity, also not uncommonly seen, especially in younger patients. Unfortunately, the lower right-hand side image is the malignant one, but you can already see that the imaging features here are quite different. First of all, unlike the first two lesions, the borders of this hypoechoic lesion, which is marked by the white arrow, are very ill-defined. You can just see a sort of a ghost of a hypoechogenicity, but then you do not really have the ability, if you were asked with a pencil to sort of outline it, that would be extremely difficult. Note also that unlike the lesion in the middle, where the orientation was more horizontal, the orientation in this lesion is becoming more vertical. As a matter of fact, you can see that posteriorly the lesion extends really relatively deep into the underlying chest wall pre-pectoral fat and fibroglandular tissue. So this is unfortunately a breast cancer. The diagnostic capabilities of radiology obviously have moved from simple visual assessment, whether for qualitative or for quantitative purposes, to invasive diagnosis, in this case image-guided biopsies. In the image provided, we can see that the lesion, which is the same lesion that was shown on the previous image, the hypoechoic lesion, has now been biopsied, and the biopsy needle is being imaged during the procedure. The biopsy needle is this very thin hyperechoic line, because it is metal and is marked by the white arrow. Now remember that when we choose the image guidance, whether ultrasound or whether another modality, we usually base it on the modality that has shown the lesion best. For example, on the image here provided, this lesion was very well seen on ultrasound, so image guidance for biopsy is very appropriate. But let's say that the lesion was simply microcalcifications and there was no associated mass on ultrasound. Then the use of another technology such as stereotactic biopsy, which uses a technology that is very similar to mammography and just varies the orientation of the images during the acquisition. Now, I haven't talked about the use of MRI in patients with breast cancer, but MRI has been also utilized in patients with breast cancer, whether patients who have breast implants, patients who are post mastectomy with a suspicion for contralateral or a high risk for multifocal disease, and there are other indications. But for those lesions that are also visible on MRI rather than on other imaging modality, we could also perform an image guided biopsy using MRI in these cases. We have already learned earlier that lung cancer is one of the cancers for which we can screen for. And the question here is, which of the following is the appropriate modality? Let's start by, for example, CT. Well, I did show you images of the lung and abnormalities on the lung from a CT. And even though you might not know the details of that, I'm sure you would agree that CT is likely an appropriate modality for screening. Now, let's beware that because CT is a modality in which ionizing radiation is used, and that's already going to put the patient at risk of radiation related unintended or negative consequences. We could always use very low dose technologies that allow us to identify abnormality, but with the lowest or the least amount of radiation needed. Let's go to ultrasound. What do you think? Well, I'm sure you would agree that even though ultrasound can be used, for example, to detect pleural effusion, because ultrasound is good to assess for fluid-filled structures. It is also good to assess for example, cystic lesions. In the case of the thorax, ultrasound can be used to assess for pleural effusion, and it can detect even small amounts. But remember that lung cancer arises within the lung parenchyma, and air is, as you have learned in the previous lectures on ultrasound, is the worst enemy of ultrasound. So obviously it doesn't make sense to screen with a modality in which the origin of the lesion, in this case the lung, would cause lots of artifact and would interfere with the images. What about X-rays? Well, X-rays are a very commonly used imaging modality in patients with suspected chest problems. Patients who come with chest pain, with cough, shortness of breath. All of these patients undergo chest X-ray. Actually, chest X-ray is one of the commonly performed radiological examinations worldwide. And it was indeed sort of tested for its ability to screen for lung cancer. However, remember when we talked about lung cancer, or when we talked about screening, we said the disease or the technology has to be sensitive. X-rays, unfortunately, are not sensitive enough for smaller lesions. So the sensitivity for lesions below 1 centimeter are extremely very low. It's still good for larger lesions, but it is not sensitive enough for the smaller lesions. Well, if it is sensitive for the lesions, why can't we still use it? Well, remember, we said that you need to have a modality or a screening test that would alter your capability of improving the patient's prognosis and outcome. If a patient has a cancer that is 3 or 5 centimeter that can be easily seen on X-ray, we know already that this is a relatively advanced disease, and therefore the prognosis and the outcome is not going to be the same as a lesion that is much smaller. MRI, I have to say yes, in the literature it is mentioned to be one of the modalities to screen, not very well standardized though. Advocates of MRI have suggested that we could alternate with CT, for example, 1 year with CT and 1 year with MRI. But I think the technology is still not at a good level for screening for. Since we have just talked about lung cancer screening, let's highlight a few criteria or guidelines for lung cancer screening that emphasizes the points that we have mentioned earlier. So number one, obviously, you are looking at screening for patients who are at high risk. Who are these patients? Obviously, smokers, either active or quitted in the last 15 years, because the risk of cancer remains high even after quitting for years. The risk of lung cancer increases with age, and therefore you might not benefit if you start earlier, but you might rather want to wait until the patient is at the age of 50 or 55. The guidelines, I have to say, have been variable depending on the clinical trial and the country or countries that were involved. But overall, the screening age has been overall between 55 and 75. You might not benefit a lot from screening very older patients, because the survival in most of the countries beyond, let's say, 80 years is very small. Now, because of the risk of radiation-induced cancer, obviously you don't want to screen for cancer while exposing the patient to a significant amount of risk. So this is more of a benefit sort of weighing process. And here, using very low techniques with doses as 0.5 to 1.5 millisieverts are advised. This is a heavy smoker who underwent a screening CT for lung cancer in 2017, as we can see, and the examination at that time was normal. He came then almost a year or a year and a half after, later in 2018, for an annual screening, and at that time, and I'm sure you already identify the abnormality, he was found to have a nodule in the right upper lobe. Obviously, because this is an early nodule and the patient was asymptomatic, the concern was very high for a lung. We have already mentioned that radiology contributes to non-invasive but also invasive diagnosis, and this is through image-guided biopsies. In this case, the patient with the new right upper lobe lung nodule went for a CT-guided biopsy. Obviously, because the nodule was seen on CT, then it makes sense to also biopsy the lesion on CT. And just to orient you on this image, so the patient has been tilted. The top of the image is actually the muscles around his scapula, and the hyperdense line marked by the red arrow represents the needle hitting the lesion, marked by the short red arrow, and the image here is acquired to confirm that the lesion itself has been successfully sampled. This case here is for a 62-year-old smoker who presented to his family doctor with cough and shortness of breath. A chest x-ray was done, and I'm sure you can already identify the abnormality here with the left lung large mass. Now, in this case, obviously, the suspicion is quite high, and this was already confirmed by a transbronchial biopsy. So a transbronchial biopsy is a way of sampling a tumor, but through a scope that is introduced through the trachea and then passed into the left main bronchus in this case, because the abnormality is in the left lung. So patient with lung cancer, what would you do? In a patient with a proven cancer, including lung cancer, you want to manage the patient. Now, for lung cancer and many others, surgical resection is one component of the treatment. It could be done alone or in combination with chemotherapy and or radiation therapy. Sometimes the disease is far advanced than you could manage it with surgical resection, and therefore treatment with chemotherapy and radiotherapy becomes more appropriate. Now, what decides the line of management? It's actually the stage of the disease. So obviously in this patient, we want to stage the disease. We want to see how much advanced is the disease. Now, CT chest is appropriate for staging the local extent of the disease. In this case, CT chest with contrast is preferable because, as you can already see on the chest X-ray, it's very close to the mediastinum. The mass is located in the left perihilar region. It's encasing the left main bronchus, marked by the red arrow. It's encasing the aorta, also marked by the shorter red arrow, and extending to the midline. This is a very locally advanced tumor based upon the CT chest. Now, even though surgical treatment is the main treatment line, in this case it would probably not be. As a matter of fact, in different tumors, staging is done using different criteria. In the case of lung cancer, we use a system known as the TNM staging. The T stands for the tumor extent. The N stands for the nodes, or in particular lymph nodes involvement, and the M stands for metastasis. What we just did in the previous case using the CT chest was a tumor assessment for the locoregional extent. Basically, you look at the size of the mass and what are the structures that are being involved. In our case, for example, the main bronchus, vascular structures, etc. Nodal extension of the disease is also an important aspect of the TNM staging. and it has its own implication in terms of regime for treatment. While we could identify lymph nodes, both normal and abnormal on CT chest, the sensitivity is not as high. And the literature have shown that in the case of lung cancer in particular, the sensitivity of 18-FDG PET is higher. And that's why, because of the important role of managing the nodal extent, for nodal staging, it is advisable to do a PET CT. Now remember that even though PET CT has been made available in many centers, it's not available everywhere. So let's say it is not available, then you would use the CT chest for nodal staging, and you can complement that with more invasive assessment, like for example sampling using different technologies such as endobronchial sampling using ultrasound guidance or even surgical access during the surgery, or prior to that using mediastinoscopy. For metastasis, definitely 18-FDG PET will help in completing the picture, and we can replace the FDG PET if it's not available with a CT abdomen, depending on how far and advanced the disease locally. In most of these stages of lung cancer, it is advisable to do specific imaging of the brain, and this is because of the high chance of metastasis. It could reach up to 1/4 of the cases having brain metastasis in specific types of lung cancer, but also because it has implications in treatment, sometimes by treating the metastasis on its own. So detection early is extremely important. Now, we can do that either by CT brain with contrast, or we can do it with MRI of the brain without and with. Now, the use of MRI brain is of particular importance in asymptomatic patients. Symptomatic patients might probably benefit just from a CT of the brain, since it is expected that those lesions will be easily. The case that we just have seen previously and being represented by the image at the top is a good example of a tumor that is designated as T4, which means a tumor that is invading the mediastinum and the major vessels. The top image is therefore is assigning the tumor part of the TNM. But remember, we mentioned that we need to do the nodal staging as well as detection of metastasis if present. The lower left-hand side image is obviously from an FDG PET in the coronal plane. And here you can see that the mass on the left side, being marked by the yellow arrow, is hypermetabolic, so it is showing FDG uptake. There is also a small lymph node marked by the white arrow on the right side, which is the contralateral side. In the nodal staging, a nearby lymph node on the same side is either N1 or N2 disease. When it is contralateral or outside the thorax, like for example a supraclavicular lymph node, these are considered N3. The presence of an N3 brings the stage of the cancer to at least stage 3 disease, which means a disease that is more advanced. Now remember, the tumor assessment on its own is not enough to assign the final stage or the clinical stage. We need other complementary information to assign the final stage. The lower right-hand side image is obviously from an MRI of the brain with contrast, and here you can see the hyper-enhancing lesion in the left frontal lobe, marked by the red arrow. This is obviously metastasis, and metastasis always signifies stage 4 disease. We use the term B for extrathoracic metastasis, like to the brain or to the abdomen. The A is usually used for intrathoracic, like for example to the parietal pleura. We will move now to another also common cancer, actually commoner than lung cancer in the kingdom, but less common than lung cancer worldwide, and that is colon cancer. Now, just to clarify, for colon cancer screening, endoscopy or colonoscopy is an appropriate screening modality. However, imaging has also been introduced over the last 2 decades to screen for colon cancer. And the question here, if you opt for an imaging type screening for cancer, colon cancer, which modality would you choose? We haven't talked a lot about fluoroscopy. We did not talk about, for example, imaging of the esophagus or of the colon using barium enema. But these are some of the imaging modalities that are also present. So the question here, is it going to be barium enema, MRI abdomen, X-ray abdomen, or CT colonography? You can pause the video and think about the answer. So in the past, barium enema has been used either to assess patients who come with symptoms related to the colon, but also has been tested for its ability to detect for colon cancer. However, the sensitivity was not found to be high. So obviously it's not an appropriate imaging modality because it is of low sensitivity. MRI abdomen is a very advanced technology, and even though it could be used to assess for the bowel in specific conditions, for example, like inflammatory bowel disease, etc., but in particular, the use of MRI has not been really advocated or tested well or shown to be appropriate for colon cancer screening. X-ray abdomen, I'm sure you would agree, the sensitivity has to be even lower than barium enema. And that leaves us with CT colonography, which is the right answer. So what is CT? CT colonography is a type of examination in which CT is used to image the colon. And because we want to identify lesions that are either in the form of polyps or that are in the form of masses, like the image shown on the left-hand side, we need to distend the colon after cleansing it for a few days. So after cleansing it, we bring the patient to the radiology department, and then we distend the colon with gas, either air or with carbon dioxide. And as you can see on this image, we can easily see the part of the transverse colon distended, and then the lesion which is being marked from the outside by the double-headed yellow arrow. Now, in addition to the direct visual assessment on the images from CT, we can use reconstructions to perform what is known as virtual colonoscopy. And this is represented by the image in the middle. So you actually create a three-dimensional image from the inside of the colon using a software. And you can see here that the small polyp, which is seen in the conventional colonoscopy in the right-hand side image, is represented very well on the virtual colonoscopy in the middle image. This slide here summarizes the role of imaging in colon cancer. As we already mentioned, CT colonography is appropriate for screening, usually at-risk patients who are 50 years or older. Once a diagnosis is confirmed after a conventional colonoscopy and sampling of the tumor, staging needs to be performed, and this is usually done using a CT abdomen and pelvis with contrast. We can sometimes add a CT chest if we suspect extension beyond the abdomen into the thorax. MRI in particular has been found to be quite useful for rectal cancer staging because of the high tissue contrast on MRI, which is relatively lower on CT. Remember, CT is appropriate for abdominal imaging and many of the pelvic abnormalities, but certain pelvic organs like the prostate, like the uterus, and like the rectum are not very well visualized in the CT. And MRI, with its added advantage of higher contrast resolution, helps in imaging those different organs, and as a matter of fact is considered to be the primary imaging modality for staging those diseases. MRI can also be used when liver metastasis is suspected on a CT abdomen but cannot be confirmed, or if the patient has, let's say, on a follow-up after surgical resection, evidence of recurrence by serum markers, but the CT abdomen is negative or not showing the abnormality. And this is simply because MRI abdomen or MRI in particular has a higher tissue contrast than CT, and therefore it is capable of identifying smaller and more occult. You hopefully remember in the lecture on nuclear medicine and PET-CT, I shared a case of lymphoma, and I am going now to talk a little bit about the role of imaging in lymphoma in more detail. Now, as I already also mentioned earlier in the lecture today, that even though lymphoma is considered a common malignancy worldwide, including in the kingdom, There isn't yet a proven way for screening for it. It affects different age groups, both young and older, and it does not really have a very high association with known risk factors, like, for example, the cigarette smoking in the case of lung cancer and others. However, staging of lymphoma is required, just like any other or most of the malignancies, to manage the patient and decide on the management plan. Most cases of lymphoma get treated by chemotherapy with or without radiation therapy, and the specific treatment plan depends on the stage of the disease. So, how far advanced is the disease? An early stage is characterized by a single group of lymph nodes, and if there are multiple groups but still on the same side of the body, for example, right or left cervical lymph nodes, then that's considered a higher stage. If we have multiple groups, but on different sides, above or below the diaphragm, then that's considered a third stage. Remember that the spleen is considered part of the lymphoid system and is being treated just like a lymph node, but designated S on the staging scheme. Lymphoma occasionally, especially when very advanced, could extend beyond the lymphoid tissue. For example, we could see lymphoma involvement in the lung, in the heart, as well as in the bone. Apart from the initial staging to decide on the treatment, imaging is also used for follow-up of patients on treatment to assess response to therapy. Now, out of all the malignancies, lymphoma in particular has benefited a lot from the advancement in nuclear medicine and the presence of FDG PET or PET-CT in general. I think I have shared this case already, and you can see in this case the patient has more than one group of lymph nodes. There is a group in the right side cervical group, and in the mediastinum in the right paratracheal group. So these are multiple groups, but on the same side of the body, and in particular above the diaphragm. You can see the fused images showing the hypermetabolic lymph nodes in their anatomic location for more precise localization. And remember that the color scheme represents the intensity of the uptake, which uses a unit known as the standardized universal or unit value, SUV. And you can see that there is high intensity or uptake of the hypermetabolic abnormal lymph nodes compared to the normal uptake in different organs. For example, in the liver or the spleen or the rest of the other organs. Remember also, because the brain obviously has a very high metabolic activity, it appears as hypermetabolic or of high uptake on the FD. This example, which I probably have also shared in the previous lecture, shows how we can follow up treatment response in the lower set of images. We can see that the activity in the cervical lymph nodes have almost disappeared, and there is some residual activity in at least one lymph node in the right paratracheal group in the chest, which is marked by the black arrow in the middle lower image and white arrow in the left-hand side lower. The different clinical indications that I have shared so far, either in this lecture or in other lecture, have really focused on diagnosis, whether non-invasive, like imaging of the abnormality, in this case tumors or malignancies, or even invasive diagnosis in terms of sampling using imaging guidance, whether ultrasound, stereotactic biopsy, or even CT-guided biopsy in the case of lung cancer, and many others. But the role of radiology have really extended tremendously beyond diagnosis. And even though there is a very subspecialized field in radiology known as interventional radiology, in which imaging is used to more invasively diagnose but also treat diseases. Many different imaging modalities have been used to guide therapy. There are different modalities of therapy or treatment, for example, cryotherapy, which uses exposure to extremely low temperatures, thermal ablation, which uses high temperatures, either using radio frequency or other sources of heat. The thermal ablation or radio frequency ablation is abbreviated RFA. And it has been used in different organs, for example, the kidney, as well as in the lung, also others. Image guidance has also been used to guide targeted delivery of chemotherapy or even sometimes radiation therapy. This has been described as chemoembolization. So basically, we deliver chemotherapeutic agents to specific lesions, for example, in the liver, with the guidance of angiography, which is visualization of the vessels, and we actually sort of embolize those tumors to deprivate them from blood supply needed for their growth. This is a patient who has a renal mass, as seen on the CT on the left-hand side image, marked with the red circle. The lesion is located in the left kidney. And the right-hand image is showing a focused view during radiofrequency ablation of the tumor. You can already see that the patient obviously is put prone so that we can access it from the back easily. And then probes that deliver radiofrequency will heat the tumor and will cause its necrosis and death. The radiofrequency probes are marked by the red arrows. Now, even though the imaging has played an important role in therapy itself, including including deciding on the plan of surgery plus minus chemotherapy, radiotherapy, etc. Imaging has also played an important role in more guided surgical treatment. And this happens in particular nowadays commonly because we have started screening more for diseases, detecting them at an earlier stage where they are either small or not palpable easily. A good example would be in the lung, where a nodule is detected on screening but is either ground glass, where it's not palpable almost ever, or solid but rather small. In the upper image, you can see a ground glass nodule, so a nodule that is not really of solid constituents. It's located in the left lower lobe and marked by the black arrow. This lesion will not be palpable by the surgeon. But even if the lesion is solid, the advancement of surgical techniques now have allowed the use of scopes. So thoracoscopic surgery, for example, in comparison to open thoracotomy, will limit the ability of the surgeon to palpate the lesions. So even for the lesion shown in the left lower hand image, which is marked by the circle, palpation of this small lesion is more difficult during thoracoscopy. So localization here is very helpful. We do that by introducing a coil under CT guidance in order to make it easier for the surgeon to identify where the lesion is and resect only that part of the lung that contains the abnormality. Localization has been also used a lot in breast surgery, especially in the presence of microcalcifications without concomitant masses. Obviously, microcalcifications will also not be palpable, and therefore localizing them with wires would be helpful to guide the surgeons on where to perform the surgical resection. By this, we come to the end of the lecture and also the end of the course. I really would like to thank you a lot for your commitment to the learning process. I know this was an extremely exceptional situation with lots of challenges. E-learning, even though I do realize that there is lots of facilitation and support through it, but it's probably also relatively new to you. I hope me and my other colleagues have delivered to you to the best we could the knowledge needed for your level, and no least best of luck not only in this radiology course but also in the rest of the courses.